think it's about time to start. We'll try to move as quickly as possible. The purpose of the hearing today is to try to discuss the specific procedures that members of the optometry profession would like to practice in Mississippi, which they now are prohibited from practicing. And we have a presentation by the optometrist. I would ask y'all just to proceed however you want, come to the microphone, whatever, and we can go from there.
Well, thank you, Mr. Chairman. As always, we appreciate the opportunity to meet with you guys again today. Per your request and based on COVID, we will keep our comments as brief and informative as possible. So one of the asks at the last hearing was a discussion of the types of procedures that we're asking to perform. And I would like to go through those with you. But first I want to state that today we're talking about procedures and not procedure codes. And we had a discussion last time about how these CPT codes that we use to file insurance are different than the actual procedure itself. And what I mean is, and the opposition has done a great job at actually highlighting this for us, that a lot of the procedures on the eyelids, some of the cysts and skin tags and things that we might seek to remove, those have various CPT codes. So you're having all these different codes that line up pretty much for the same type of procedure. So trying to limit our discussion today to a formulary of CPT codes is actually burdensome, and truthfully it could result in something as crazy as us being able to perform a procedure on the right eyelid and not the left eyelid. So that's why we maintain that it's actually best if our state board decides which CPT codes optometrists are allowed to do based on our training. And so what we're asking is that we're asking you for the ability to perform these actual procedures and then allow our state board to decide which codes fall within those guidelines. So let's go ahead and walk through some of the actual procedures here. You should have in your handout a sheet that looks kind of like this with a list of procedures. I'm going to go through each one of those. Can you guys hear me okay? All right. Okay, first on the list, we are talking about removal of eyelid lesions, and these are presumed non-cancerous eyelid lesions. Now, the reason we say presumed is, certainly there are clues that may give us an idea of if this lesion might be cancerous or not, but not always. And so we always take precautions if we remove an eyelid bump and have that biopsy to be sure. But the removal of these lesions, they're small lesions, would not require any significant closure, and oftentimes not any at all. I mentioned to you last time about chalazion removal, and I told you that, when you have a sty, sometimes the leftover material from your body fighting that sty forms a hard bump. And that bump can be small and just unsightly, or if it's large enough, it can press on the front of the eye and actually cause some visual changes. Now, of course, we always try to resolve any of these chalazions with more palliative type therapy, but sometimes they're just resistant to our normal therapies, and it does require making a small incision to remove that, or in some cases, which is actually the next procedure, injecting a medication into that chalazion to make it go away. The subconjunctival injection, the soft tissue on the white part of your eye, which is clear, is called the conjunctiva. And that is actually the tissue that gets inflamed when you get the pink eye, so to speak. And so sometimes it's advantageous for us to inject medicine underneath that soft tissue between that and the white part of your eye for inflammation or infection. I mentioned to you last time also about the removal of the secondary membrane after cataract surgery. So when you do cataract surgery, you have to remove the lens of the eye. That's where the cataract's located. That lens is located in a sac we call the capsule. Well, if the surgeon does a good job, the capsule's left in place, and that's where you put the implant so that you can see. The reason for the implant is if you take a lens out of a camera and you don't put one back in it, you're not going to get a very clear picture. So sometimes when you put an implant back in, over time on the back side of that, a layer of cells starts to grow. And we call that sometimes a secondary cataract. Very, very simple way to remove that using what's called a YAG laser, and in just a few minutes actually, it clears the patient's vision right up. This is a great example of something that we could do in the office. If I'm seeing a patient, if Dr. Moore is my patient, and I'm looking at this patient and say, you know what, all you've got is a secondary cataract. I can take that patient into the next room and have that done in just a matter of minutes. And then we'll talk about access again a little later on, but just the burden of me having to stop and make an appointment with an ophthalmologist to do a 5-minute procedure requiring extra time, requiring sometimes a wait of a few weeks to a few months. It's really so simple and much better care for the patient if I can just do as I'm trained and take care of that on the spot. The next three actually procedures relate to glaucoma. I don't intend to educate you on being an eye doctor today, but glaucoma, you need to know, is simply an eye disease that typically causes, well, it actually does, it causes damage to the nerve that connects your eye to your brain. So all of us as optometrists have glaucoma patients, and in my practice in McGee, we have quite a large glaucoma practice. The mainstay therapy is eye drops, and we treat most of our patients using eye drops and doing so successfully. There are cases in which you may want to consider doing a laser procedure. For instance, if a person is sensitive to a particular medication they can't use, this could be advantageous to lower the eye pressure, because you're always looking to treat, that's the only variable we can control is the eye pressure, so that's the goal, is to adjust the eye pressure. If a person happens to be on multiple medications, you know as well as I do, if you're taking 5 medications, you're likely to forget one occasionally or not be as compliant. And I'd love to say all my patients are compliant, but just sometimes they're not. So this can actually help to improve compliance. And then some patients, you can actually do this procedure on the front end and avoid them having to be on medication and avoid those copays and so forth to start with. So the SLT is a type of laser procedure. These procedures are directed at the drainage system of the eye. When fluid is made, it comes from behind the color part, it comes to the front, and it drains out. If you get leaves in your gutter, it's going to back up, okay? And this is similar analogy in the sense that the drainage is, if we open it up more, we get more fluid going out, and that's the goal of using these first two procedures. Now, there are cases where that drainage system happens to get a little bit more narrow or close off, and of course, in that case, the pressure is going to shoot up quite a bit. That's where our third procedure comes in, and that's simply a procedure to make a new pathway for the fluid to flow. In that way, we can resolve that issue. So that is a list of the types of procedures that we're asking for today. Now, in our last conversation, we had a discussion about optometric education, and I'd like to make a few points on this. First of all optometry students are trained to do the procedures that we're asking to do. And it was very evident from our past hearing that our opposition has no knowledge of our training and apparently no desire to learn. However, I want to commend many of you who've actually taken us up on our invitation to visit SCO in Memphis and have seen firsthand that our students are trained, in fact, the way we say. And if you happen to be new to the committee or you haven't received an invitation yet, we certainly will send that to you as soon as COVID allows. Secondly, it was mentioned that optometrists who have graduated since these procedures were taught actually learned them through a weekend course. Let me kind of highlight that for you. First of all, I don't know of any doctor or other professional for that matter who goes back to their respective school when new information or procedures come out. Now, you correct me if I'm wrong, but I don't think attorneys go back to law school to learn new law. And I know dentists don't go back to dental school, and medical doctors don't go back to med school. All of our learning comes through building on our base through continuing education that adds to our knowledge. This weekend course, as it's claimed, is an attempt to downplay education. And actually, some of these courses are over 30 hours, which is almost the equivalent of a college semester. I reviewed a manual the other day for one that's over 830 pages long. So this is actually not just given out. You actually have to pass a rigorous test in clinicals as well. And I want to point out, this is not unique to optometry. Medical school graduates do the same thing. I mean, we have courses. That's how you add to your knowledge base, is through continuing education and then through specialized training when you need that. You don't go back to professional school. Third, I wanted to say that last time there was a comparison of our optometry hours in training versus the ophthalmology, and quite frankly, that's really a moot point. We pointed out that ophthalmologists spend most of their training on complex surgical procedures that we are not even asking you to do. Now, if you would like some proof of this, I'd refer you to a letter by Dr. Rich Castillo from Northwestern University. He is both an optometrist and an ophthalmologist. He has been through training on both of those. We must consider that optometry is really more like dentistry. We are trained to do the primary eye care procedures, just like dentists are trained to do their primary procedures. Optometrists and dentists go to school for the same amount of time, and as I mentioned the last time, we often attend, along with medical students, the same classes in the first couple of years. Dentists graduate, they're allowed to make incisions, they're allowed to suture, and they're allowed to do other procedures, whether it be under local or general anesthesia, as needed. It would be absolutely laughable if a dentist stood before you right now arguing the right to do a dental procedure, but yet here I am doing that for optometry. I'd also like to mention some of the erroneous data that you've received from the opposition. They brought to you a report from the state of Vermont about optometric education. Now, personally, I don't really think many of us in Mississippi give a rat's rear end about what happens in Vermont, but let me point out that this report is significantly flawed, and it's based on many false assumptions and a lack of data. I don't have the time here to address each point, but we do have about a 15-page handout that does go over those inaccuracies, and I would encourage you to read through that to correct some of the falsehoods. Also, the maps that you've received from the opposition are simply another way to muddy the water. If you read our labels, they are accurate. All we're attempting to do is to show the states that have a greater authority than Mississippi. We really weren't focused on certain privileges, and the key on that was just simply a guide. As to their misleading claims on surgical authority, I would refer you to the procedures map chart that we created. It's in your handout. Let me show you real quick here. It looks kind of like this. This is accurate information, and it actually shows you exactly what each state allows their optometrists to do. Also, this information is accurate as of July the 31st. I believe it's been shown that we know our education and our states better than the opposition. The point is that nothing we gave you was ever meant to look deceptive, and nothing was untruthful in any way. Finally, I want to address what came up last time about our lack of judgment on procedures and our lack of ability to handle complications. So let me point out, first of all, that these procedures, when they're needed, well, guess who's sending them to the ophthalmologist to be done? Okay, if a patient needs to have a YAG, then I'm sending that patient, which means I had the judgment in the first place to know they needed it. I don't get patients back from ophthalmologists saying, I'm sorry, they don't need a YAG. That person, the ophthalmologist, does that procedure and then sends them back to me for the follow-up, or oftentimes we call that post-operative care. And that's where your complications come in. You know, right now we provide the vast majority of this post-operative care for even complex procedures like cataract surgery. We're fully aware, even if we don't do the procedure, how the procedure is done and what potential issues might happen afterwards. Now, it's brought up that, hey, if you have a YAG, you clean the implant, your pressure might go up. Well, guess what? I'm just simply going to treat the pressure. It's what I do right now. Okay, so there is no issue with us to having the lack of judgment to know when to do these procedures, and us being able to handle any complications afterwards based on our state law. I would like to take a moment to introduce to you Dr. Stacy Moore, and I'd like her to just take a moment to address some of the access issues we discussed last time from her perspective in her hometown practice.
Hello everyone. I'm Dr. Stacy Moore and I practice in West Point. So the biggest thing regarding access to eye care is when you're in a rural community, 20, 30 minutes can be actually 3 or 4 months away. Most of my patients are on public assistance, require calls to public assistance transportation services to schedule for these type of services they may need that I may be able to provide that I'm able to provide in my office on many occasions. So patient transportation issues is one of the biggest things regarding access to care. Their working children, friends, and family members may have to take off work to get them to these places as well. And with that being said, that also is a delay in terms of their schedules. So it just becomes a little bit more of a layered thing when it doesn't necessarily have to be for some of the services that we are able to provide. With regard to the same day service of some of the different things that you just heard about, including Chalazion, that is something that can be done right there with their trusted doctor that they see year after year that explains detail with them on every procedure that is done. And they know that they are in good hands. Someone who's trained, who's qualified, and in some states licensed already as an optometrist to do these procedures. I have a huge population of glaucoma. I see patients every day who have to, one, either on 3 drops, that's a little much. One, as far as patient compliance, and then as far as patients having to have an ocular issue where it's irritation that may be developed because of these drops. So we're limited in what we can do in Mississippi, and it's unfortunate because I graduated over 20 years ago, and I'm still not able to practice to the full scope of my competency. I feel as if the patient care should be centered in all of our discussions in terms of what they need and what we're able to provide them with. So access, again, can be hours if these laws are passed. Greater access will help in time efficiency and will give our patients the quality care they need and will have Mississippi recognized as a forward-moving state in the care of optometry and what we can provide. Thank you for your time. Steve, back again.
Thank you. I was going to ask members if they had questions. Are we at a place to pause, or do you have?
Well, Senator, if I may, I just had kind of a real quick wrap-up summary.
Sure.
Just a few minutes.
Feel free to wrap.
Okay.
We haven't had anybody wrap all year.
Had it wrap in a while? Yeah, well, I'm not a really good rapper, I'm afraid, but I'll try to summarize to the best of my ability. So a few take-home points to leave you with. So we were asking to do primary eye care procedures that we were trained to do. And regardless of what the opposition says, some of these codes are actually surgical codes, but really they're primary care procedures. That's what I want you to think about there. Optometrists in all of our neighboring states are allowed to do more than us in Mississippi. It is a disservice, as Dr. Moore said, to the citizens of Mississippi to not allow optometrists to perform the procedures that we are trained to do. A lack of geographic and timely access does create a real healthcare disparity in Mississippi, and optometrists are trained and we are willing to help with that problem if given a chance. Finally, I want to say optometrists have a track record of safety and success. You know, the Bible says the way you tell a prophet is whether or not the predictions come true. Well, I'd say that for about 50 plus years, the opposition, every time we come to you, tells you the same thing. We're going to blind people or we're going to kill them. Even something as simple as many years ago, us discussing whether or not we could put drops in your eyes to dilate. The same thing happened at that point in time. Looking back, I'd say that the predictions aren't coming true because I don't think we've killed or blinded anybody yet. So I would consider that none of these predictions have happened. I'd be very wary of any future predictions that you're hearing about today. So that's all I had, Chairman Bryan. I want to thank all of you, and we would be happy to answer any questions for you.
Thank you. Are there questions? Senator Polk? Former Vice Chair Polk.
Okay. Thank you, Mr. Chairman. Question. If the law changes and optometrists are allowed to do many of the, I'm going to use the word procedures that you're requesting, you've not had that opportunity in Mississippi. Many of you have only practiced in Mississippi for 20, 30 years. What will be required, you think, for you to get proficient again in performing these operations?
Yeah. Well, it's a good question, and I will assure you that our state board is very, very tough on us when it comes down to making sure that we protect the public. Of course, any training would require a renewal or a didactic course for us to learn, make sure we're up to date on the latest education parts, because, you know, knowledge of medical care even though we have CE, it does exponentially increase each year. So we would go back and do a thorough deep dive into that. Also, there would be wet labs. There would be practice on models, patient models, that would allow us to get proficient with that as we've done in the past, like back during school. I will say real quick, even though this is not a procedure we're asking for, I was visiting a college of optometry. The students there were actually practicing in a wet lab a procedure, and it was great to just do the hands-on and to actually see, because ophthalmologists train the same way with them. So, but that also followed by very rigorous testing and proven proficiencies. It's not enough to say you can do it. You've got to prove you can do that. And so, just like the last time we passed a bill, when we had to, we were expanding some oral authority at that time. We had a very extensive class and test on that, and we take that seriously.
Thank you, Mr. Chairman.
Senator Wiggins, were you once vice chair of this committee?
I was, Mr. Chairman.
Sir?
I was, Mr. Chairman.
Yet another former Vice Chair Wiggins.
I think that's a positive. So, thank you. May be surprised a little bit at this question, but you mentioned, and this question also, when I guess the folks from the ophthalmology get up, they can answer it too. But I'm just curious, you mentioned like the lawyers and the medicine and and it seems to me like what we do is we go, if you train to be a doctor, you train to be a lawyer, you train to be a whatever, then you go out and you're able to apply your trade. And we don't really go in and we, the legislature, and say, you know what, you as a lawyer, you can't file this motion, you can't file that motion, you can't file this motion. But yet, in certain things, podiatry, optometry, we, the legislature, and if I understand what y'all are asking, you want us to say, hey, these are the things that you can do. I think I've asked that. Why are we here? If you're going to a school that you've been trained and that has been certified as an optometrist, why is the legislature involved in telling what procedures you can do or can't do?
Well, that's
And why? And I guess I'm going back historically. Why is that even the case? Why has that been the case?
Okay, well, that's a great question, and I would love to be able to say I don't know. I will tell you that if you look back through history, all the way back to the DOs, the medical community has always fought any kind of expansion of any particular profession other than themselves. The fact that DOs are included now is because, over 100 years ago, they went through the same kind of battles. Podiatrists, they battled them. Nurse practitioners, they battled them. So the reason why is because pretty much we can't seem to get anything else done unless we come to the legislature. That's bottom line. So we've been forced to come to you to recognize our trained ability to do those procedures.
Anyone who's not a former vice chair? Senator Horn.
I'm looking at this document that starts out surrounding states, and then there's another document, the Mississippi Optometric Association, examples of procedures with general explanation. Is this what you want to do in the way of additional services?
Are you referring to the top up there?
This document right here.
Oh, yes. Let me get over here to that. I'm sorry. I thought you were looking at the map document. So, yeah, these are examples of the types of procedures that we're asking to do in Mississippi. Mm-hmm.
That you're not currently legally able to do.
Exactly.
And you're representing to the committee that you've been trained to perform all of these procedures while you're in optometry school.
Yes, sir.
And when we were talking a few weeks ago, it looked like you were going the route of, here's what we don't want to do. Here's what we're not asking to do. But this sort of fine tunes what you actually do want to do.
Yes, sir.
Okay. Thank you.
And if I might point out, the reason I harped on what we didn't want to do the last time was it's always misportrayed that we want to do cataract surgery, we want to do retinal surgery. I want to make it clear we weren't asking for those complex surgical procedures that ophthalmology does. I just wanted it to be fully transparent.
Thank you, Mr. Chairman. Thank
you. I think at this time we need to hear from the ophthalmologist. thanks to y'all for your presentation. I know the ophthalmologist and the State Medical Association wish to make a presentation, so we'll hear from y'all now.
Mr. Chairman, members of the committee, Dr. Crowder, who is the head of the ophthalmology department at UMC, will address from the Mississippi Academy of Eye Physicians and Surgeons, and then Dr. Horn for the State Medical Association, and then at the end I'll wrap up with a comparison of the maps of what's available.
Good afternoon. Thank you for your time. I'm going to go backwards just a little bit to answer Senator Wiggins' question. We've also wondered, why there's not just one medical board for all medical procedures, but there's not. We do all have separate boards.
Legislation right there.
There we go. That's probably not for today, but that would be one solution. Thank you for your time today. First, Chairman, I know you asked about last session about the number of states in the U.S. where optometry's regulatory board has the authority to determine the scope. And currently, that answer is 1. Alaska is the state that has full authority to determine their scope. There are other states that have broader authority, but the majority of the states all have, including the 10 that are listed on the optometry handout, they all have, they are bound by some degree by legislative oversight. If the 10 states had full authority, then they would be doing the lasers and the eyelid incisions, but they don't. It's just Alaska right now that gives that authority. I'm going to leave to my colleague to address the CPT thing, but yes, no, CPT codes never define surgery, and the AMA, their handbook never intended for that handbook to define surgery. Another thing I would like to point out is general anesthesia also does not define surgery. I keep hearing that, well, these procedures won't use general anesthesia. The great majority of everything that ophthalmologists do in surgery do not use general anesthesia. So that is also not a good descriptor of, whether something should be, a surgical privilege or not. And then, once again, the, claim that increase in malpractice does not equate to complications, that is not a good, fact to use either, because as I said before, malpractice is set, by actuaries. It's not set by, medical professionals. And so it's only a game of numbers, and the great majority of optometrists do not do these procedures, so it hasn't been enough for the actuaries for it to be a blip on their screen. Most importantly, out of all this is I know what it takes to train a competent surgeon. This is what I have devoted my entire life to the past 17 years, is training students to become competent surgeons. I understand the standard of training. I understand that this involves years of one-on-one apprenticeship with direct supervision by a physician treating live patients. I hear the words, from our optometry friends that the training is the same. The training is not the same. The training differs hugely by a number of years. It differs hugely by direct patient experience with direct supervision by a physician in order to perform surgery. I hear the word simple again, and I tell my patients, no matter what procedure I'm going to do to them, there is no simple procedure if it is your eye. There is no simple procedure, because if God did not read the textbook when he made your eye, then it may not be a 5-minute procedure. Nobody in this room is identical. And so to say something is simple, yes, that it's fabulous if we do have cases that are shorter and that are uncomplicated. But to give that promise that all of the procedures being asked for are simple is erroneous, because there are complications that occur with these procedures. When we have these patients that have the complications with them, we do not send them back to the optometrist. The ophthalmologist deals with the complications. Often from some of these procedures, those complications mean that we actually have to go to the operating room to fix the complication. And that's something that for us is, down the hall or across the street if we have a surgery center, or if we're on faculty of a hospital. So it is right there. And so that's the important part. If there is a complication, it's imperative that the patient is right there with the surgeon who can fix the complication. Lowering standards does not equal better patient care. And I know that the governing body has a history of finding ways to protect patient care, to protect patient access to high quality care. Mississippi has not lowered the standards based on patients' zip codes or based on their socioeconomic status. They are finding ways. One way, like I mentioned last time, was the Rural Physician Scholars Program. Another is the Office of the Physician Workforce. Mississippi has done a really good job of finding ways to make sure that patients continue to have their access to trained, competent surgeons and high quality care. And by the way, ophthalmologists are not on the list of the shortage on the Office of Physician Workforce. We're not on that shortage list for Mississippi. So we are there. We are here to serve our patients and to provide procedures and surgeries that our patients need. Like I said, the procedures that are being asked for, anything on the eyelid that you do, if it is not done correctly, can have forever consequences to the patient's eyelid function and could to their vision. The surgical procedures using lasers, it is still surgery. It is still destroying tissue. Just because it is not with a scalpel does not mean that it is not a surgery. And like I said, these things have complications with them that, if not identified immediately and corrected immediately, then can cost the patient's vision. So I'm happy to answer any questions. Otherwise, I'll turn it over to my colleague.
If I remember correctly, I may have got the wrong impression. When you were nice enough to appear before us previously, I thought I understood you to be saying that you thought the existing law about what optometrists were permitted to do was too broad. Did I get the correct impression about that?
I'm sorry, I didn't understand.
I'm sorry, it's hard to know,
I know.
What to do. My impression from your previous testimony was that you thought the existing law about optometry was overbroad and allowed optometrists to do procedures that they shouldn't be allowed to do. Did I get that correct impression?
Well, the previous one that was introduced last legislative session, right, just was so expansive that you could interpret from it that it included 150 to 200 procedures.
Well, but the question I was asking is, I thought you said that the existing law in Mississippi that we have right now itself was too broad and allowed optometrists to perform too many procedures.
I did not make that statement.
Okay, I'm sorry. It was an exchange with someone.
And let me say, I'm not here to throw my optometry colleagues under the bus or to criticize them. They are the primary care eye doctors for the majority of patients in Mississippi. If we don't have optometrists, then our patients will suffer. I am not here to give any impression that we don't need optometrists. We need to work together on this. But the training is different, no matter what anybody says. The training is different.
I don't take the position personally that anybody here is here in bad faith or that anyone is here to attack another profession. I take it to be the position that there are different people with different perspectives, and they're here to share with us their viewpoints and their perspectives. Are there other questions? If not, thank you, and you have other people who wish to talk to us.
First, can you hear me with that mask on? Okay. First, briefly to readdress the question that from last time about CPT codes. The testimony at the last hearing about CPT codes, I believe, reveals a deep misunderstanding and is revelatory as to why the procedures that are being requested. I believe that the requesters do not understand what they don't know. They didn't understand the CPT codes, and the AMA, who wrote the CPT codes in a letter that you each have, clearly states that their presentation last time was a complete misunderstanding of what the CPT surgical codes, quote unquote, meant. Surgeries, procedures. And it also clearly states that anything that disrupts human tissue, whether it's a knife, we all know that if you cut someone, you're operating, but there's a desire among patients, I see this all the time, and it seems to be one perhaps among some of our optometry colleagues to try to tell people that a laser is not, it's basically a fancy knife. It's a high energy, focused, light knife. It destroys tissue, it divides tissues, and it is a form of surgery. So those are two things I wanted to make the point of about the letter that you have from the AMA, and I would request that you read it carefully. I have to explain complex things to patients every day, and I have found over the years that analogies and stories are often the best way to do that. So if you bear with me a second, I'll tell you a quick story about how I view some of the guiding principles for me as I practice medicine. A lot of you may remember Donald Rumsfeld, our former defense secretary. You don't have to like him or dislike him, but he had a fairly famous quote that I personally found useful. There are known knowns. There are things that we don't know. There are things that we know we know. There are known unknowns. That is to say, there are the things that we know we don't know, but there are also unknown unknowns. There are things that we don't know. And I think that's the problem here. Without adequate training, you don't know what you don't know. Physicians have the training to know some of the things that are being requested, reveal that the requesters don't know what they don't know here. A version of this concept is something I use with every medical student. I tell them, know what you don't know, and know what the difference is. How can you do that? So it gets to the story. I served in the 1st of the 181st Field Artillery Battalion of the Tennessee Army National Guard. In 1991, we were mobilized and sent to in Desert Storm. I was their battalion surgeon. Now, I'm an internist. So those of you who know physicians know, any of those you know surgeons, I'm not a surgeon. And I did not allow having that title, battalion surgeon, to make me think I was a surgeon. I knew that that was the way the military said doctor. And those of you who've been in the military probably are familiar with that. So my job was to provide for the day-to-day health care needs of the battalion, whether they were in garrison, whether we were training at Camp Shelby or at Fort Campbell, or if we went to war, which I did with them as well. Because of my training as an internist, lots of critical care, lots of complex medical care, I knew what my limitations were. I had surgical colleagues that I trained right alongside. I knew what they did, I knew what I did, and I knew the difference. By nature, I'm a very intensely curious person. I like to know as much as I can about everything. I'm just curious. So because I'm curious, and I was with a bunch of guys in very large 8-inch cannons, those of you who like guns and hunting, there's nothing better than heavy weaponry, I asked a lot of questions. And because I would go anywhere they went, whether it was in the field, didn't matter where they went, I went there with them. And they respected that, and they would bless me and grace me by telling me as much as I wanted to learn. So I learned a fair amount about 8-inch cannons and 50 caliber machine guns and light anti-tank weapons. They let me shoot all those things. It was a fascinating time. I spent years with that group, thousands of hours. I went to a lot of different places, including Saudi Arabia, Iraq, and Kuwait. Even though I spent all that time and they taught me all that about artillery, I never once thought of myself as an artilleryman. I spent lots and lots of time with them. I knew a lot. I knew way more than a passing knowledge of artillery. I never once thought I was an artilleryman. The people who were artillerymen went to special artillery schools. They spent years in training under very experienced people and gradually worked their way up through the ranks to become the section chief, chief of smoke, the battery commander. After I left that unit and I returned home to practice in Laurel, they came to Camp Shelby, and the Army had decided to retire that 8-inch self-propelled howitzer. So this was the last hurrah. And because we had such a great relationship, they invited me down, and they said, "Doc, you want to fire one of the last shots out of these cannons?" Of course I did. They let me stand on that weapon and handed me the lanyard and said, "Okay, Doc, pull the lanyard." I did exactly what they told me to do, and a 210-pound high-explosive round went screaming downrange, right where the meteorology section had fed the information to the fire direction control, who'd fed that information to the chief of smoke on the gun, who'd set the right charge and the right azimuth, who'd had the aiming stakes out, who had everything set perfectly so that that round would splash exactly where it was supposed to, about 10 miles away. What was the consequence if they had made a mistake? Death, maiming, destruction. But I was okay to do that because they told me exactly what to do. The people who knew, who had the training, who had the expertise, they told me what to do. I was in the company of well-trained professionals who'd spent years honing their craft under supervision, direct supervision, and observation of experienced mentors and instructors. They'd gone to schools just to learn how to do this. And that was the difference. When they let me stand on the carriage of that massive cannon, they told me just pull the lanyard, and I knew that it was going to be right. They knew what they were doing. I had more than a passing knowledge, but I was not the person who knew what to do, who could have done that. I understood what was happening, and those experts, because they trusted me to listen to them and follow their direction and understand that they were protecting me from the things that I did not know, and even more importantly, from those things that I did not know that I did not know. Thank you.
Let's see, Ms. Clay, do you want to finish the presentation?
Janet, has the handout been done with this? I'd like to call your attention to the handout that looks like this. The premise that has been before you in the last two hearings is that Mississippi's law is more restrictive for optometrists than the rest of the country. This map will clearly show you, and our research establishes, there are only 5 states in our United States that allows for laser, scalpel eyelid surgery, and injections. They are Alaska, Oklahoma, Arkansas, Louisiana, and Kentucky. You are being asked to allow optometrists to perform laser surgery. You're also being asked to allow optometrists to do scalpel eyelid surgery and injections. In addition to the 5 states that allow laser, there are 2 other states in the country that allow scalpel eyelid and injections and no lasers. There is one other state, Iowa, that allows for scalpel eyelid surgery with topical anesthesia only and injections. So throughout our United States, there is only a total of 8 states that allow for either laser and/or eyelid and injections. In other words, there are 42 states that do not allow what you're being asked to legislate. If you'll look over with me to the next page of the handout, you have been given this map by the Mississippi Optometric Association. It indicates that there are additional states that allow for the removal of lumps and bumps. Then they say that there is one state that allows for oral steroids, and then use of injections beyond anaphylaxis. Now in Mississippi, we do allow injections for anaphylaxis for reactions. If you will, but even in their own map, they show you in the green that there are only 5 states that allow for laser surgery. If you add the other states that are in blue that supposedly allow for scalpel, if you research those states, that is not the case. There are only the states that I went through with you before with the total of 8. Oregon does not allow, nor does Idaho, scalpel surgery. And that is included on the map you've been given. And we can back that up with statutes. The purpose of the American Academy of Ophthalmology, there are daily searches and research done on what each state law allows. And this information is directly from that association and that research. I did for you a step-by-step, side-by-side on the next handout of what Alabama does. There'd been some question about them being even more less restrictive than Mississippi. In reality, if you look at that, the only thing that Alabama allows that Mississippi doesn't is some access to controlled substances, 3 being one of them. Mississippi allows for 4 and 5. I think it is significant, too, if you look at the maps, and their own maps, the optometric maps, the 2 places that the majority of the optometrists in our state are trained. There are 2 places, Southern College of Optometry in Memphis and University of Alabama Optometry School in Tuscaloosa. Tennessee does not allow for laser surgery. They allow for scalpel surgery for some incisions. It limits the degree of it, the size of it, etc. And they allow for injections for local anesthesia, to perform the scalpel surgeries that are allowed. In Alabama, there is no laser, no scalpel surgery. So the 2 places that our optometrists are mainly trained, those 2 states allow not what you're being asked to allow. You were also given the request for certain procedures. We have included an example of some of the laser surgeries, some of the injections, and some of the scalpel that you're being asked to approve. Please read the descriptions of those surgeries. Then I want to point out that we've been told that there is because of our present law, optometrists are not coming back to Mississippi to practice. I have included in your handout the latest budget request of the Mississippi Board of Optometry. And their statement to the Budget Committee was There are over 440 licensed optometrists currently practicing in the state, and generally an additional 20 to 25 seek to obtain a license through an examination yearly. If you go back and search their budget requests for the last several years, you will see an average of 20 to 25 new members. You were also given a map like this in your email that appears to make Mississippi stand out as one of only state in our whole surrounding area that doesn't allow these procedures that you're being asked to do. Let's take Alabama. No procedures, although it's colored blue in your handout. Georgia has no surgical procedures. It's blue in your handout. Tennessee, as I said, does scalpel, not laser. Kentucky, above us, not an adjoining state, but above us, they do allow both. Louisiana, adjoining us, does. Arkansas allows laser and some restrictions and scalpel. Texas has no surgery, no surgical procedures. Florida has no surgical procedures, although they're not on your map. If you will look at the ophthalmic procedures authorized by state, it is not reported that Mississippi allows for the removal of foreign bodies. Code section 7319-151 does allow for optometrists to remove superficial foreign bodies. You're also not told under Mississippi that under Code Section 7319-157 that optometrists can prescribe all non-injectable medications that are listed in the current annual edition of the Physician's Desk Reference for Ophthalmic Medicines. It's a broad range of what can be prescribed in Mississippi. That's not included. And that can all be, I can read some of them that's right there in our state law. Prescribing of non-steroidal and anti-inflammatory medications for medications for viral infections, all kinds of drugs, anything that is in the physician's reference desk for ophthalmic medicines can be prescribed today in our state by optometrists. You're told in Alabama that they can prescribe oral steroids and oral immunosuppressive drugs and Schedule III. Well, under the physician's desk reference, the first two, oral steroids and oral immunosuppressants, are listed for ophthalmic medicine. So the only thing in Alabama that's of any significance here is Schedule III, which Mississippi doesn't allow. But that's because this state has been very careful in allowing the prescribing of controlled substances. So yes, Alabama does allow for Schedule III. Tennessee has no laser, scalpel only. And the only two states in this handout that allows for surgery of any sort is Arkansas and Louisiana. They leave Tennessee, Tennessee's there with just scalpel. On the last handout, which is a comparison of all the states, and it's this document that looks like this that you have. I think it's significant if you will look at that. The things that we were asked to talk about today was laser surgery, scalpel surgery, and injections. Those are the things being proposed. If you look at those three categories, first, ophthalmic surgery, which is laser, 5 states, their own document shows you that. If you look, so that means that 45 states prohibit it. 5 allow, 45 prohibit. If you look at the next category, removal of growths, and then previously those have been called lumps and bumps, their documentation says 12. We have an issue with that. We believe it's only 8, and it's on the map that I showed you, the very first map. But even if it were 12, that's 42 states that don't, 38 states that don't allow it. Under our research, there are 42 states that don't allow it. But even this document proposed by the Optometric Association, it's 38 that do not allow it. The state board authorization procedures. We showed you the research from the American Academy of Ophthalmology that shows that there are only 3 states. Alaska lets them have full authority. Oklahoma and Kentucky allows some authorization, but with limitations by statute. But there again, if you take their research, 21 states out of 50. So Mississippi's still in the mainstream. The last category I want you to look at, because the next ones deal with drugs, mostly controlled substance drugs, hydrocodone. I've already explained the oral steroids and the immunosuppressants, which are covered under our statute. But look under injection authority. Again, they say 20, we say 8. Our research shows 42 states prohibit. Their research shows that 30 does. So you take all of those categories that we're supposed to be talking about today, Mississippi is in the mainstream. We are not a restrictive state when it comes to the profession of optometry. Thank you, Mr. Chairman. Thank you, members of the committee.
Is this all the presentation from the ophthalmologist? Thank you. Do members of the committee have questions for any of the people here on behalf of the ophthalmologist? Did you want to ask a question?
Yeah, for Ms. Clay, please.
Sure.
Yeah, thank you for being here, and I think you did highlight one important point in your discussion. I think the last time we made a change in the law, you mentioned the physician's desk reference for ophthalmology and for ophthalmic drugs. Are you aware of the last date that that book was printed?
I am aware that that is what physicians go by when they are prescribing drugs. There are some later online versions than the desk copy that I have had in the past, but yes, I'm familiar with it.
So it's my understanding the last print edition for that was around 2010 or so. I might be off by a year or so.
Yes,
but I wasn't able to find the online edition either. But I highlight that point because the last time this committee mentioned this, and this is to Senator Wiggins' point, we as, I think, whatever profession we're in, we have some degree of expert knowledge in what we do, and we are tasked sometimes with understanding what we do and regulating what we do to some degree. And so would it not be true that it would not be fair for the lobbying association to be managed by the medical association as far as what you can and can't do as a lobbyist? Would you say that's a fair statement?
I don't see a comparison there as to any point that you are making. And I don't believe that the medical profession oversees other professions. I think that our education system does. So if you look at the different schools, if you look at the definition of...
So my question, though, in all due respect,
Okay.
was would it be fair... I'm sorry, I had a dental procedure yesterday, so I'm still... My voice is recovering a little bit here. But would it be fair for, one profession to be, overseen by, or regulated by another, just in general? Would that be a...
Well, I don't know what your point is with this, but I think that the legislature oversees lobbying. There are laws that govern us. I don't
Right, so
know
it would be more fair for the legislature to oversee lobbying as someone who understands it than it would be for optometrists to oversee lobbying.
Well, I would think the optometrists do oversee your own lobbying group, but
Right, but
I guess it
I don't,
depends on...
I think the point you were making was that it's not really appropriate for optometry, the Board of Optometry, which a few years ago we decided was an important enough board that we kept it. So a number of us debated and talked about boards that we should remove, and we did remove some. And that's just one point there. And then I just want to make this point too, and I'll just do this with you here because my goal, Mr. Chairman, is to be brief if I could. It highlights again when we see one study from one group, one study from another, and we hear 8 here, and we hear 12 here, and we hear 20 here, and we hear 15 here, whatever the numbers might be, it just strikes me as being a misunderstanding of what's going on in the training. And so Dr. Reed provided a letter today that I found very interesting, that it's a letter from an optometrist who later went back and became an ophthalmologist.
I'm familiar with that.
And what it goes through is his, or I don't remember if it's his or her, but the provider's perspective on the training they received in both curriculums.
Right.
And I don't know of many people who do that, but I found that interesting because I, in general, I don't know how dentists are trained because I'm not a dentist, but I do find that it's interesting when we see that, and so I'd ask, you and other members of the committee to look at that. And then for the Medical Association, I appreciated your comments today, but I think the same thing occurs because, you mentioned the AMA letter about procedure codes. And, my point in the last hearing, and I know I had a lot of things I wanted to mention, was to say that in general, most of the surgical codes for ophthalmology are in the 60,000 group. And I'll highlight that in the book that you gave to us at the last meeting in section 4. We have code 65210, which is the removal of a foreign body conjunctival embedded, which is a procedure we are allowed to do in Mississippi. And right underneath it in your handout that you provided to us is 65235, removal of a foreign body from the anterior chamber, which is a procedure we're not authorized to do and do not want to do. But the point I was trying to make in my discussion is that there is some intermingling, and we all know as providers, we're not experts on coding. I've got an excellent staff member who, she is fantastic. She gets calls from, multiple professions and speaks about coding and is the true expert on that. But my point was that, there is that misunderstanding amongst professions. And I'm hoping that Senator Bryan's discussions have at least gotten us to the point where we understand that we don't know what other professions do. And I thank you for coming today.
Thank you. And your reference to Dr. Reed, I wanted to say he did make a very good point when asked by Senator Polk what education they would have, and he said that they would have didactic training and practice on models. So the models are not human being eyes. And I just wanted to leave you with this comment. As you consider how you would vote on this issue, I wish that you would ask yourself, would I allow someone who has not been to medical school, who has not had a residency in any kind of surgery of the eye, perform these procedures on my child, on my spouse, on my parent? And if you answer no to that, I ask you to think about, are you allowing that for the constituents that sent you here and the general public of Mississippi?
And Mr. Chairman, since she added a closing remark, I would add to that I would invite Ms. Clay sometime to come to the optometry school and see students from Mississippi doing the very procedures that is being asked to do here, as some of the members of this body have done. But again, thank you for being here.
Senator Horn had indicated he had a question.
Thank you, Mr. Chairman. I guess to Ms. Clay, since she was the last speaker.
Just pick any one of them you want.
Say again?
Just pick any one you want to answer your question.
Well, I'll ask my question and then let whoever wants to answer it respond. A couple of times, well, to the last point that was discussed, these procedures that are being asked for, optometrists are saying that they're being trained in school to perform. And I think I've heard Ms. Clay and her comments indicate, and I think we heard it in the last hearing, that the procedural training is on inanimate objects, dummies, dolls, whatever you want to call it. But the training is not performed on actual human beings. And whoever wants to respond to that.
Because I do these procedures. So, not the procedures we're asking for clearly, but corneal foreign body removal. I learned how to do that in school. I didn't practice that on a person who had a foreign body, but I do it all the time, and I have not blinded anyone by doing that procedure. I have learned how to use intramuscular type of injections, subcutaneous, and subconjunctival. Those things were trained to us, so we are capable of handling needles. We were trained to use those needles. We did practice on each other as patients on how to do those procedures of injecting saline into the conjunctiva. We've learned how to do the things that are being said on competency. I just wanted to say is invalid. The progression of our profession has gotten us to a point where we have colleagues who practice and do the laser procedures that are not in any way harming patients. No one deliberately takes the oath, the optometric oath, and goes and does reckless, callous things to patients. We're here for the betterment, to help the quality of life of our patients, not to harm them in any way. So to remain stagnant in this state is not an option. I mean, the quality we need to provide our patients is already laid out. Again, we've had the training, we know the knowledge, and the things that need to be enhanced upon, there will be brought to you all from our board to get those things done so everybody is up to par with making sure we can get these delivered to our patients.
I guess to my point, I'm trying to compare the levels of training. Yes. And is it the representation of the Optometric Association that the kinds of training that they're given to perform these laser procedures that you're asking for, is the training parallel and comparable to what ophthalmologists are trained for?
Currently, well, if we want, we can reference part of the letter that someone who's uniquely qualified that you have on the table to have both an optometric and ophthalmology degree has stated with regard to that training. And this is on the second page. These are not my words. These are words from an ophthalmologist optometrist. It's highlighted in green. Today's doctors of optometry actually acquires more formal transcript-accredited graduate-level didactic and clinical coursework over 4 years dealing specifically with the eye, anomalies of vision, and disorders of the eye and eyelids than their ophthalmology resident counterparts do in their entire medical school plus ophthalmology residency careers. I did not make this statement, but that goes to answer your question.
Take that as a yes.
Correct. Yes, Senator. Thank you.
So I heard the word coursework, and yes, the basic hours that you sit in the classroom are similar in some optometry schools, okay? What is different is that after, in medical school and in residency as well, as after you sit through the didactic, which means, somebody's lecturing you, what is different is going to actual patient care, direct patient care. Yes, we do have simulators and models similar where we can start the training, but the difference is the actual performing procedures on patients with real pathology to understand how the human tissue is going to react, not how the model tissue is going to react. So that is completely different. I outlined in my last talk for, before ophthalmologists do any eyelid procedures, they have spent, at my institution, in my residency, they have spent 12 weeks doing nothing but eyelids, doing nothing but directly supervised eyelid incisions, suturing. We don't use the term lumps and bumps, but removing lesions. Okay, so 12 weeks on direct patient care. The laser training, yes, we can start in a classroom, we can start with lectures, but then the residents actually go perform these procedures on patients with real pathology. The patients with real pathology is very different than a model. And I have to be right there, one-on-one. My faculty to resident ratio is 1-to-1. Southern College of Optometry advertises a faculty to student ratio of 9-to-1. Mine has to be directly supervised one-on-one before I sign off. They have to perform things on patients before I sign off that they're competent.
So I'll take your response to my question as a no.
Correct.
Okay. One final question, and I think I want to direct this back to Ms. Clay, since she made the statement. A couple of times you mentioned that Mississippi is in the mainstream of where optometric care is concerned. If we pass the requested pieces of legislation that would allow these procedures to be done by optometrists, where will that put Mississippi in the scale of things?
Mississippi would be the number 6 state in the United States to allow what's being asked of you today.
Thank you. Thank you, Mr. Chairman.
I have Senator McMahon and then Senator Blackman, and then I think we'll come to a pause. Senator McMahon.
Mr. Chairman, thank you. My question is for Dr. Crowder. Hey, Dr. Crowder. I have a question. You said that you had been an instructor or a professor for how many years teaching in ophthalmology?
Since 2003. I haven't been a professor, full tenured professor, until 2015.
17 years in the profession?
17 years, yes. Starting as an instructor, working my way up to assistant professor, associate professor, and then full professor at UMMC.
Would you prefer I address you as professor or doctor?
No, you can address me as Kimberly.
Well, you've earned it. You've earned it, doctor, so I'll address you as doctor. Are you performing procedures today the same way, the same type of procedures as you were performing 17 years ago, or has that changed?
So thankfully, technology and innovations do change. That's good. My base training, though, provided years and years of basic surgical training so that I could adapt quickly to these new technologies. I still know how these tissues react. Even if we come up with something new and, a better, faster way, I still am trained at the base in order to understand how human tissue acts to a laser, to a scalpel, to an injection, to, whatever we throw at it. I know how that tissue is going to react from my experience on patients.
You use the word innovation, and I think that's what's before this committee. One of the things before this committee is, the technology has changed over the last 25 years in both the professions. And what I encourage, and I've said this publicly, I'm addressing all the presenters today, I encourage your professions to find a compromise between you. It's better if you guys can find those compromises in the private sector than for us to find a legislative remedy. Because if we take up legislation and we find a legislative remedy, then this body will decide. And I think it's best for both of your professions to decide where compromise, surely there are some compromises that can be made. I have personally toured the optometry school in Memphis. I've seen it with my own eyes. I was amazed by the technology. And like I said, that I just cannot impress on each of you enough that I think that some compromise could be found of some type. I do want to ask Dr. Stephen Reed a question.
Excuse me. Drive me crazy. All right.
Dr. Reed, have you been trained in surgery of the eye?
Well, according to our colleagues, it depends on how you define surgery. If surgery is manipulation of tissue, then doing a corneal foreign body removal is surgery, and the answer would be yes.
How many years have you served as a doctor, an ophthalmologist?
Well, optometry, 25.
How many?
25 years.
Have you seen innovation within the profession in the last 25 years?
Just exponentially so, yes.
Is there new equipment?
Absolutely.
Are there new types of drugs available?
Yes, for sure.
Would you in any way perform a surgery that you felt like you might endanger someone's eye permanently?
No, not at all, not at all. We take an oath to only do what's in the best interest of the patient, and we stick to that oath.
Thank you for taking my questions, Mr. Chairman. Thank you.
May I add one thing to that real quick?
Sure.
So to Senator Horn earlier, I mentioned models, but we do have training on actually patients. Matter of fact, in Oklahoma and in Kentucky, I'm only going to speak for those states because I know for sure, part of their training includes working with a doctor who's already trained in that area to perform these procedures on humans after perfecting it in the labs.
Senator Blackman.
Thank you, Mr. Chairman. And this is to Dr. Reed. Dr. Reed, in your 25 years, have you ever diagnosed anyone with an aneurysm?
Yes, I have.
What about a brain tumor?
Yes, I have.
Diabetes?
Every day.
And do you prescribe medication for?
For the treatment of diabetes?
Yes, sir.
No, I don't treat diabetes, but I manage the ocular complications from that.
Okay, so if you diagnose, if someone is determined to have diabetes, then they have to go to another physician.
Right, if I find that, yes, I send them to the appropriate internist or endocrinologist for treatment of their diabetes, exactly.
What about high blood pressure?
Yes, same thing.
And high cholesterol?
Yes.
Rheumatoid arthritis?
Absolutely.
And then you have to refer them someone else? You have to refer them to someone else?
Yes, if I suspect rheumatoid arthritis, I do send them to the appropriate subspecialist.
And what about multiple sclerosis?
Yes, very much so.
And then you have to refer them?
We go to the neurologist, right.
And are you trained in medication toxicities? Yes. I'm not sure which medicine you're referring to, but I don't have any.
one of the common medicines that we monitor for toxicity in the eye is called Plaquenil, which is used to treat rheumatological conditions.
In optometry school, do you all get pharmacological courses?
Yes. Matter of fact, the pharmacology is very similar to dentistry and medicine because those are some of the same classes in that first couple of years.
Okay, they're similar to dentistry, but not to...
Medicine too. We're not just learning in pharmacy school about eye. We have ocular pharmacology, but we're also learning about systemic pharmacology as well. We need to be trained to recognize if a person's on a medication for a certain systemic condition, whether we prescribe that or not.
Okay, and I guess my last question is, when you received your degree and you came to Mississippi, did you know what your restrictions were?
I didn't hear the very first part of what you said. I'm sorry.
When you, 25 years ago,
Right.
and over the course of your 25 years, when you made the decision to, I guess, come back to Mississippi or come to Mississippi, I don't know what your background is, did you know what the restrictions were for optometrists in the state of Mississippi?
You know, I had an idea, and I'll tell you why, because the year that I graduated was one of the years that Mississippi updated their law, and so it had been brought to our attention exactly what it was that we were not able to do before, but that the law changed. So yes, I was aware of that, and I can tell you that our students now are acutely aware of what's going on because it's discussed quite often.
Okay. Thank you, and thank you, Mr. Chairman.
Thank you. Is there anyone here with the optometrist who feels that there's any information you to give us before we leave that we haven't had? Yes, did anything that was presented strike you as something you thought we needed more information about?
I can provide some insight, if I may, on a few of
Sure.
the things that were brought up earlier. First of all, I don't really quite understand the whole CPT, whether we call it surgery or not. The truth is, we're not trying to be artillerymen, as was mentioned earlier. We simply want to be do the procedures we're allowed to do. First of all, the maps were not any kind of a trick or a disguise here. The maps were simply meant to highlight the states around us. And the reason for that is our patient bases in the South are very similar. We have a lot of disease in the South. So our patients in Louisiana and Mississippi and Oklahoma and Kentucky, those patients are like we see in Mississippi. We need to have the procedures available so that we can take care of those patients in Mississippi in the same conditions. It was mentioned earlier about how our state board, it looks like we have plenty of optometrists graduating. Well, just because they graduate and come back to Mississippi doesn't mean they stay in Mississippi. The other day, what I mentioned to you were people that actually had left the state after coming back. But it is a consideration that not everyone who comes to Mississippi goes to rural Mississippi. Do we have a physician shortage in the Delta? I would say yes. Most optometrists graduating today don't want to come back to rural Mississippi because in rural Mississippi, where we're treating most of these eye diseases, we're not allowed to do all the procedures that we would like to do. They instead go to some of the more urban settings. So just because you look at a certain number of graduates from the state does not mean that we're adequately taking care of all the patients in Mississippi, not to mention that the patients in Mississippi, the population is certainly growing every single day. I would also refer you back, two more quick points. One, it was mentioned about the standard of care and about lowering the standard of care, or lowering quality of care, excuse me, that was the term that Dr. Crowder used. I want to point out the standard of care in Mississippi is the same for optometry and ophthalmology. If I do a procedure on a patient, I'm held to the same standard of care as an ophthalmologist. So allowing us does not lower quality of care, it continues the same standard of care. I also wanted to highlight one area. The only reason that I've ever used the word simple is simply to highlight the fact that we're not asking for the complex cataract procedure, or not complex surgical procedures that the opposition, that's their field house, and we want them to continue doing that. And I will echo Dr. Crowder's comments that we get along very well in the state, and we do respect their role in that care, but we simply want to be able to do the things that we're trained to do in Mississippi to take care of our patients. And with that, I will end unless there are any more questions.
Yes.
I have one last point to Senator Blackman. It was a question that you were asking concerning, a question that you had concerning the level of the amount of how much it costs to go to optometry school versus medical school. The data shows for just Southern College of Optometry in Memphis, average is about $38,200 per year for non-contract students versus UMMC, which is at $37,000 plus or minus $37,200 there. Thank you.
Is there anything that those of you with the ophthalmologist feel that you should say before we go? Sure, Ms. Clough.
I wanted to make sure you got the handout on the rural areas after that was brought up. In the states, if you look at the state of Mississippi, you will see that the ophthalmologists are within easy driving distance, but I wanted to explain also in the states that presently we have ophthalmologists going to satellite clinics in Kosciuszko, in the Delta, and Macomb, various areas that may not have a resident ophthalmologist. They have access through satellite offices. Also, we have documentation that shows that in Louisiana, after surgery was passed, the rural areas are not where the surgery's being done. They're all congregating in New Orleans, in Baton Rouge, in the metropolitan area. So you do not improve rural health care access by passing this legislation. Also, in response to the question about why is the legislature involved, if you look at the handout that I gave you last hearing in the notebook, it shows you how this issue was brought to the legislature. In the early 80s, a group of optometrists got together and worked up an exam. It was called the National Board of Optometry Exam. And they said, if we devise an exam that certifies optometrists to do treatment, pre and post-op surgery treatment, the optometrists will go into the states and they will get this legislation passed. That was in the early 80s. They said by the end of the 90s, this will happen. And true, it did. By 1998, all of the states had passed legislation expanding the scope of optometry. That's how it came to the legislature. And then, about 5 or 6 years ago, the same man that proposed that solution in the early 80s said, we'll do another exam. We'll give it to fourth-year optometry students, and it will be an exam for surgical procedures. They devised the exam. In your booklet, I believe it's under tab 88, they did it on plastic models. They taught suturing without human skin. They devised the exam, they gave it, and said, by the end of the 2020s, we will have it in all of the states again, just like we did in treatment. So that's how this issue came to the legislature, and that's the history, and it's documented through a publication of the Optometric Association in your booklet from last time under test points, and it explains both exams and how they came about. Thank you, Mr. Chairman.
Senator Blunt said he either had a question or a comment or both.
Thank you, Mr. Chairman. I just have a request of both the optometrist and the ophthalmologist. What I'm trying to do, maybe most of the members of the committee are trying to do this, is to find out what exactly is being requested and get the maps like this. Ms. Clay sort of did this with the chart that was provided by the optometrist. And I don't know if this handout from the Optometric Association is exactly what's being requested when ultimately, assume we're going to see a bill when we convene, what's being requested, and whether, and I understand there are differences of opinion about this, but whether both sides can give us a map that we can rely on that as closely as possible lays out what the lay of the land is in the 50 states for the changes that are being requested to current state law. This is helpful from the optometrist, and Ms. Clay talked about this and the chart that was provided, but those are simply those are simply the facts and the lay of the land as it exists today in the state, and there are differences of opinion about whether that should be changed or not, and I understand that, and we're going to think about that. But what I'd like to know is what's being requested, and whether, as closely as possible, each side can determine whether those procedures are allowed in other states or not, so that when we come back in January, we can take all this paper and condense it into one map and one list of procedures that are being sought. So I would ask that of both of you. Thank you.
Thank you. I believe it is now been formalized that Senator Tate and Senator Blackman are members of the committee, and I've not officially welcomed you, so on behalf of the committee, welcome. I think we have two good new committee members. For reasons escaping human understanding, Senator Polk has been named vice chairman of some committee, I don't know what. So that has opened up a slot for vice chairman, and we now have Senator Parker as vice chairman of the committee, and we're very happy to have Senator Parker in that position. I also would like to say thank you to everyone who came here to present today, the people who've come to present previously. I believe that all of the information we have has got the committee as a whole in a better position than we were when we started this undertaking. And I know that all of you have other things you could be doing, and as I've said many a time, all we did was just win elections. We don't necessarily know anything about machinery at all. I think we've done about as well as we can do under this circumstance. I hope to see you all in January. I hope not to see you for a very long time in January. Thank you.